allow people to still kind of filter in, just so that Sandra has enough time to get through all the material. Um, Thank you for being here for our monthly clinical management session. A question that's arisen a few times now from some of our country teams is how to better instruct clinicians on endotracheal intubation. And I know some of you have had some formal training in this, and some of you have not. Several sites have mentioned that skills and comfort with intubation are low amongst the frontline staff, and this is something that may be decreasing the number of patients making it onto the ventilators. Much of our initial learning materials only gave this procedure a very cursory glance. In reality, although it's a quick procedure, it's quite tricky and it's quite a dangerous moment for the patient. And clinicians who attempt this procedure without the right training are often unable to place the endotracheal tube successfully, although it seems like it ought to be simple when you just glance at the steps. It can be quite difficult. And having errors during this moment can cause decompensation and mortality in the patient during the procedure itself. So I know not everyone has had the luxury of extensive training on this, and that makes it harder for you to develop further training and offer advice to your doctors. So today we have a special guest, Dr. Sandra Lopez from Johns Hopkins, and she'll be speaking about the nuances of getting this procedure right and go into some real detail about it. And hopefully this will leave all of you a little bit more comfortable with offering advice and facilitating trainings on this. Feel free to ask questions as we go along, or save them up for the end. So Sandra, thank you for being here, and I'm going to pass the mic on to you. And we can see your slides.
Okay, perfect. Good morning or good evening, everyone. Thank you for the introduction, Nico. My name is Sandra Lopez, and I'm a fourth-year resident in emergency medicine. So this is a procedure that we learned to do early on in our training, and I'm happy to have the chance to talk to you about it today. Please feel free to ask me any questions or any comments during any time of the presentation. So let's get started. So in terms of what we're going to be discussing today is these main points that you see here on the slide. Overall, we're just going to be talking about the procedure, but it's very important to consider all the steps that go in before that and as well as afterwards. So one of the first things to consider is the reason that you're going to be intubating somebody. And these are some of the main reasons that you see here on this slide. Overall, it makes a lot of sense if you just think about it in a simple way. You essentially are going to intubate a patient if they are not breathing effectively. And that's either because they're not getting enough oxygen or not able to blow out their CO2 enough. Also for patients who are not breathing well at all and have a decreased respiratory rate. For those patients who are unable to protect their airway, either because of some kind of traumatic injury or some kind of other mind-altering substance or anything else that could be going on. You would also be intubating the patient if you are concerned that they may deteriorate in any way, and you are overall concerned about their overall clinical progression. So these are just some of the main reasons that you would do that. So once you have made the decision to intubate the patient, you need to get ready. And sometimes you have time for this. You can have a few moments to plan, to get all your supplies ready, but other times you won't be as lucky and you're going to have to do things right away. So the first thing we're going to be discussing is when you actually have time. When you have time to assess the patient and assess their airway, it's always a good idea to do these following steps that we're going to discuss, of just taking a few seconds to kind of analyze the patient's anatomy, and that'll give you a good sense of how difficult this intubation might be. There are multiple different grading scales that you can use to help you assess a patient's airway. So one of the most famous ways, or one of the most common ways that we know to assess a patient's airway is with this score called the Malampati score. Basically what it does is that it categorizes patients into 4 different classes. And then you can see here how it's depicted. I don't know if can you all see my mouse? Not sure if you can. Well, I'm not sure if you can see my
Can't
mouse,
see
but
can't see
okay, okay. So here in so it gets divided into four different categories, depending on how the patient looks when they open their mouth. So you ask the patient to quickly just open their mouth the best that they can, and based on what you see, you classify them either as class 1, class 2, class 3, or class 4. The best class, or the class that you are very happy to see, is class 1, when that's when you can see their whole entire mouth, all their soft palate, and then this structure here called the uvula. Once you get to class 2, you see less of the soft palate, but you are able to see the entire uvula. And class 3, you can only see the part of the uvula, and in class 4, you can't see any of the uvula or the soft palate. Any patient who gets ranked as a class 3 or class 4 is usually associated with a more difficult intubation. And this is a picture of what it looks like in a real individual. Here you can see more of the back of the mouth, as well as the uvula, and then that progresses to being, you can see less and less. So that's one of the ways to classify the airway of the patient. A second way is called the thyromental distance. And this is another assessment that you can do quickly for the patient at the bedside. What you essentially do is, if you look at this top picture on the top left of the slide, you can see that they measure from the tip of the chin or the mentum all the way to where the thyroid cartilage would be. And usually this just gets done with 3 fingers. And essentially, if your distance is greater than 3 finger breaths apart, as you see here on the picture on the right, usually that's a good sign that you have a lot of room to work with. Any patient who is greater than 6 centimeters is considered to be an easy or an easier airway. Whenever you see smaller than that, you get more concerned as well. And then finally, one of the other classification scales that becomes very important is this Cormack-Lehane scale. And this is actually the view that you see when you intubate the patient. So in the top, you can see the cartoon versions, and then you can see the real life versions. And just like the other scoring that you saw, the Malapati score, the lower the number, the better. So grade 1 is what you really want to see, and you don't want to see grade 4 when you're taking a look. So this is the view that you see when you put the laryngoscope blade inside the patient and you try to lift the epiglottis or lift the soft tissues. Grade 1 is where you can see the entire vocal cords. You can see the arytenoids here, which are here on the bottom. And this is the view that you definitely want to see. Grade 2, the epiglottis is obscuring the view a bit more, but you could still see the vocal cords pretty clearly, which also indicates that this would be a safe intubation. Once you get to grade 3 and 4, it usually becomes more unsafe to intubate the patient at that point. It's because you don't get a clear view. When you have a grade 3 view, you could use different tools or use manipulation to kind of help improve your view. And some people will use a device called a bougie, which we are going to discuss later to help facilitate the intubation. But the most important thing to consider about this system is that what we typically do is after we intubate a patient, we do write a clinical note in the chart, and we usually write what grade we saw. And that becomes important because if the patient ever needs to be intubated in the future, a person can look up their chart and see what kind of grade was obtained in the past. And if you know the patient had a grade that was more difficult, 3 or 4, it becomes more worrisome and you take more care before you decide to intubate that patient. And this is a summary slide just for reference, discussing some of the things that we just mentioned. It summarizes the Malapati scale, as well as the Cormack-Lehane scale, and also thyromental distance. And then there's another grading scale that involves just opening the mouth, which also uses measuring with your fingers, and you want to see that the patient's mouth is greater than hopefully 3 to 4 centimeters in distance once they open their mouth. All right, so that's a summary of the grading scales overall. So the next thing that we're going to be talking about is actually getting ready for the intubation, which I think is one of the most important things. These are the steps that will allow you to be successful. And overall, it's important to keep these 2 things in mind, that if it's possible, if you have time, preparation and positioning is going to be crucial and extremely important to help you facilitate the best possible outcome. Also, if you can recruit help or get assistance, always do so. The more people you have at hand to help you, the better. But I know that's not always available. Sometimes things get busy, but if you have any staff that you can use to help you, is great. An important thing to consider is how important it is to pre-oxygenate the patient. This is a step that a lot of people tend to forget and even forget here in the emergency departments here. Once you've made the decision to intubate the patient, you can actually just put them on oxygen, even if they weren't requiring it. Some people definitely will be requiring oxygen because that's why you needed to intubate them in the first place. But even simply putting a nasal cannula on the patient allows you to not only achieve 100% O2 saturation, but it allows all the nitrogen that the person has in their lungs to be hopefully be replaced by oxygen. And by doing this, you increase the amount of time that you have to intubate the patient overall. By pre-oxygenating the patient in any of these ways that you see here, either with a nasal cannula, a non-rebreather, high flow nasal cannula, or even BiPAP or CPAP in some cases, if that's what you have, you're increasing the amount of time that you're going to have to help intubate them. Because if you don't pre-oxygenate, you usually only have like 40 to 50 seconds before they start to desaturate. And with this technique, you're gonna add several minutes to that to be able to intubate the patient. Hopefully, it doesn't become necessary, but it is something that's helpful. And one thing that we do sometimes is that if you do have more than one oxygen source, you can actually have the oxygen connected to the bowel valve mask that you're going to be using to ventilate the patient after. And you can also have nasal cannula connected at the same time. And you can leave that on. You can leave the nasal cannula while you're intubating the patient to help maintain their oxygen saturation while you're intubating them, because it won't get in your way. In terms of ventilation, it's also a very important step in positioning the patient. These are two maneuvers that we typically do on patients. Definitely have to do the head tilt and chin lift that you see here on the left, where you essentially just lift the head and tilt it backwards, as you can see in this picture, and that really helps open the airway. Even if you don't have any of your supplies, just doing this will help the patient breathe better. As well as the jaw thrust that you see here. This maneuver also opens the airway quite nicely as you're getting things ready for the patient. And the jaw thrust is what you use particularly when the patient is unstable, may have an unstable cervical C-spine, where they have a C-collar in place. This is the best way that you can help kind of provide an open their airway. So this is a picture of a bag valve mask that you see here on the left, which is what we've been referring to. It's important to help position the face mask over the patient, as well as have your PEEP valve. Usually we set it off to 5. Usually that's where our standard PEEP is set. Here, this is the bag. This is where you squeeze the bag, and then the rest of it is connected to the wall of oxygen. And then this reservoir bag gets filled with oxygen prior to using it. When you are going to ventilate the patient and hold the face mask, there's a couple of important techniques to keep in mind, and there's several videos of this available online as well. It's important for you to hold the mask in such a way that it helps cover the entire part of the face, the entire part of the mouth and the nose. And you can hold it with your fingers either in the C position that you see here or in this E position. The most important thing to remember when ventilating a patient is that sometimes, it can be a stressful situation to be intubating a patient. And sometimes people have a tendency to kind of hold the mask into the face, and it's important not to put pressure down. You don't want to, what we call like suffocate the patient by pushing the mask into their face. You actually want to lift their face into the mask and pull backwards, kind of in the head tilt position that we showed you earlier. And when you're doing this, when you're ventilating the patient and bagging the patient, it can actually be very tiring. And over time, you get better and better at it. But if you do get tired, you could always switch out with another person, or you can position your hands in such a way where your arm is at a 90-degree angle and you're pulling backwards to help kind of position the patient and give them as much air as possible without getting too tired. So it's important to stress how key ventilation is. A lot of the times we all rush to kind of intubate the patient, but it's very important to be able to ventilate, because sometimes, unfortunately, it will be difficult to intubate the patient. And if you can't intubate the patient, you're not going to be able to provide them a definitive airway to give them the oxygen that they need. And if you can't ventilate the patient by properly bagging them, that's going to be a problem. It's a scenario that you don't want to get into. So practicing this skill is also very important. Another device that you may see that helps kind of facilitate the amount of oxygen that you can bring to a patient by helping opening their airway are these two devices that you see here on the top. We call them airway adjuncts. The first one is an oral airway, which is placed in the mouth, as you see here on the left lower picture. It's placed in the mouth, and what that does is essentially help kind of move the tongue out of the way and help create less of an obstruction to help facilitate oxygen reaching the patient as well. And you could place this while you're bagging the patient. So you can place it in their mouth, helps kind of open the airway, and you can continue to bag them. And usually it does increase their saturations overall. The other airway adjunct that we see quite commonly is the nasal airway that you see here. And that's inserted in one of the nares of the nose. You put a little bit of lubricating jelly and you insert it in the nair, and that helps also provide increased airflow to the patient. The only time that you wouldn't use the nasal airway is if you're concerned for any kind of basilar skull fracture. If you're concerned that there may be any disruption to the anatomy or the bones inside of the face or the head, you wouldn't want to use this because it could potentially create a tract into the wrong place. So the next thing that we're going to talk about is the actual equipment that you need. And this actually becomes very important to remember that you have all the things that you need. It does happen quite commonly that you'll forget to have something at hand. So it's always good to kind of prepare. On this picture here, you can kind of get a sense of all the things that you're going to be needing for this procedure. You're going to be needing your laryngoscope blade, your bag valve mask, your ET tube with stylet, your Yankauer suction, a bougie if you think it's necessary, a syringe, and some type of CO2 detector, as well as tape to kind of tape the tube and everything in place, and any of the nasal or oral airways that we just talked about. And this is in addition to everything else that you're going to need. You're going to need your ventilator, your oxygen source, as well as your medications for the intubation, and any other supplies that you may need as a backup. So one of the things that we do here, at least at Hopkins and in many places that I've trained in the past, is that we usually organize all of these tools and put them all in some type of storage device so that it'll be easy access anytime that you need it. We actually use this method here on the left, which is an airway box, and it's actually sealed, so no one can open it until it's needed. You kind of we call it breaking the box. We open the box and we have essentially almost everything that you need in there. The only thing we don't store there is medications, but some facilities will store medications inside their airway box to facilitate the whole procedure. And other places will use an airway cart, also an airway type of bag or kind of carrying case that you see here on the right. That's actually what we started doing during the pandemic. We actually started putting things in a clear plastic bag to be able to have easier access to it. But these are just some of the ways that you can store all your tools and all your supplies beforehand so you can be ready. This is actually a picture of our emergency department here at Johns Hopkins in the critical care bay. We helped develop a checklist that is actually hanging off the boom or hanging off where all the monitors are and everything are in the emergency department that you see here. Is that we developed an airway checklist so that we can have it here is a picture of it. So you can have as a reference to help you remember all the things that you need. We put this especially for our second year residents so they wouldn't forget any of the things that we needed. Is all the things that I highlighted to you before. And on this checklist, we actually have a quick reference for some of the doses of the medications that we typically use for fast access and to kind of just help facilitate the whole process. Because unfortunately, sometimes you only have a minute to prepare. Other times you have 10 or 15 minutes, but sometimes when you make the decision to intubate and they're unresponsive or they're coming from a traumatic event, you have to intubate the patient very quickly. And this kind of helps facilitate that. It helps kind of remind the provider what they need and not to forget certain important steps. So the next thing we're going to be doing is that we're going to be talking about all of these different equipment pieces, more focused conversation on all of them. I'm not sure how many of you are familiar with laryngoscope blades, but these are the two most common blades that you'll see either in emergency departments or ICU settings. They're known as the Miller and McIntosh blade. So on the left here, you'll see that this is called the curved McIntosh blade, and it's also here on the lower right of the screen. And this is a curved blade. And then the other blade that's used is the straight Miller blade. And this is what it looks like here at the top with a straight line. At first, when people are learning how to differentiate these two, we just tell them to look at the shape and then just remember that this is a straight line. So it's like an L, so that stands for Miller. And then Mac is curved like a C, so that's how you remember it's a Macintosh blade. It is called Macintosh, but no one ever really uses the word Macintosh. Everybody just refers to it as a Mac blade. And although they may look very similar, the placement of these two blades is actually very different. And it's important to remember those. In terms of the blade that is most commonly used, it depends on what institution you're in. I've been in different places where there is a strong preference for the Mac blade, as well as strong preference for the Miller blade. Overall, for the past few years where I've done my training, overall, the Mac blade is the one that's preferred. And typically users find it to be more easy and easy to use overall. So once you're using this blade, you actually, once you insert the blade into the patient's mouth, which we'll go over later on, you'll actually want to insert it in such a way that the tip of the blade enters the space called the vallecula. And once it enters that space, you're able to lift and kind of expose the epiglottis. So here on this lower picture on the left, you can kind of see where this like neon yellow is. It's going in that space called the vallecula and lifting the epiglottis, which is right underneath it. And you see a view here of what that looks like using a video camera, where you can see the epiglottis is still in your view and you can see the airway here with the vocal cords. The Miller blade is different in terms that you will not put it in that space called the vallecula. You will actually insert the blade and use it to lift the actual epiglottis. So you intentionally want to cover the epiglottis and lift, and so that you get exposure. Here, you can also see pictures of that where you no longer see the epiglottis coming into view. It's actually covered and lifted, so you can get a nice view. The size of the laryngoscope blade can also matter. Typically, if you use a bigger blade, that means that you have a bigger patient. So I'm not sure how many of you will be working with pediatric patients, but overall, the Miller blade is preferred in pediatric patients because of that epiglottis that you have to lift. The Miller helps lift it because in younger patients, it's not as stiff as it is in adults. But usually if you're intubating an adult patient, you're usually always going to use either a Mac 3 or Mac 4 blade or a Miller 2 or 3 blade for the most part. Those are the most common ones that you'll see. The larger the blade, the deeper it can go. And that is important for patients who are particularly tall or have just a larger or longer airway overall. Some people will choose to always intubate with a Mac 4, for instance, and then just position the blade outward, even though it's much longer than what they probably need. They'll be able to position it backward, not backwards, but more outward, so that they'll be able to get a good view and still see everything. And if the patient is much bigger than they thought, they'll have enough blade to be able to do the procedure. So that's something that comes with experience, and every provider has a different preferences to what they like to use. I, for instance, for the most part, always use a Mac 3 blade. It's very rarely that I have to switch to a Mac 4, but occasionally the Mac 3 blade will be too small and I will have to change to a Mac 4. So some providers prefer not to have that problem and always use a Mac 4. Another thing to consider is the actual size of the endotracheal tube. For the most part, in adults, a size 6, 6.5 to 8 is typically what is most likely used. Size 8 is usually the preferred size if it's possible in any adult, because that way they can undergo certain different types of procedures here, such as like bronchoscopy or other things, and that allows more space and allows the patient to undergo those procedures. But it does vary by age, and then this chart kind of shows you a formula that is used, particularly in pediatric patients. This formula here that you see at the top of the screen that depicts the size in millimeters. Usually if it's a pediatric patient, you will put their age divided by 4 plus 4, and that'll give you the size of the ET tube that is needed. But for the most part in adults, you're looking at a 6, 6.5 to 8 size. In terms of another thing that you have to remember is the stylet. The stylet usually comes, as you see here on the left side, as a straight line. And what you'll be doing is that you'll be inserting that into the ET tube, and you have to give it a shape. This on the right side is a typical shape that most providers will put the stylet into, is that you'll form it into this hockey puck. We call it hockey stick type shape, where it kind of curves to an L at the end. and this helps kind of facilitate the intubation. But this is it's flexible and rigid at the same time and allows you to intubate the patient. If you don't have a stylet, the ET tube can be very floppy and very difficult to insert into the airway. Intubation medications also matter, and this is also going to vary depending on your institution. You may not have access to all of these medications, but typically you'll choose the appropriate medication based on the patient's history and blood pressure. Overall, the medications that I typically use for induction, which is when you sedate the patient so that they don't feel any pain or any discomfort during the procedure if they are alert, I usually use etomidate. Usually it's a very safe medication that can be used in most patients. And in terms of paralytic, I typically use rocuronium because that has the less contraindications. And even if I know nothing about the patient, it's usually the safer medication to choose. And this is what helps paralyze the patient. There's different reasons to use any of these. And it also depends on what you have available at your institution. You also have to remember that after you intubate the patient, you need to sedate them because it's not going to be comfortable for them to have a tube in their mouth if they were awake and alert beforehand or semi-awake and alert. And that's also going to vary depending on the patient's blood pressure and depending on the institution that you're in terms of what you have access to. Here I have a reference list, of the doses that you can or should use for your patient depending on induction or you're paralyzing them. This you can refer to at any time, or you can even create a list and put that on you so that you remember, because sometimes it's hard to remember all these dosings, but once you use them with a lot of frequency, you end up memorizing them. So these are a lot of things that you have to remember to have with you. And sometimes it can be easy to forget something or one thing or many things. And that's why we've implemented the use of a checklist, because that can help us not forget things. And then also there are different mnemonics or different devices that you can use to help you remember. One of the most common mnemonics that we use is one called SOAP ME, which stands for all the things that you see here on the slide. So each letter of the word SOAP ME helps you remember different things like suction, S for suction, O for oxygen, remembering your oxygen sources, A for airway, remembering everything you need for the actual intubation, like the tube, the stylet, any kind of rescue devices or airway adjuncts, remembering to position the patient at the best possible way to facilitate a more smooth intubation, remembering your medications, and then the rest of your other equipment, including the ventilator as well. So now we're actually going to talk about the procedure itself. So now that you have everything that you need at the bedside, now you can proceed with the steps. You've given the patient the medications that you need to give them to not only sedate them, but paralyze them, and you have everything that you need with you. So we're going to be showing you some videos, but I just wanted to show, kind of describe what the steps are like from here, from the beginning. So once the patient is positioned properly and you've done the head tilt and chin lift, so to speak, you are going to always hold the laryngoscope blade in your left hand. Even if you are a right-handed person, just like I am, or a left-handed person, you will always hold the laryngoscope blade in your left hand. You are going to open the patient's mouth with your right hand, and you're going to be doing this technique called scissoring, where you get two of your fingers inside the patient's mouth to kind of help open their mouth. You're going to place the blade inside and move around any of the other soft tissue structures, such as the lip or anything out of the way to make sure that you don't hurt the patient. And then you're going to push the tongue to the left and then lift towards the corner of the room and then hopefully get the view that you want. Now, I'm going to show you a picture of what it looks like to scissor the mouth. So essentially you are putting your thumb and third finger for the most part what you can use, and you will put those in there and help pry open the mouth. Here is a good picture of it here on the bottom right, and that helps kind of open the airway. And I cannot stress how important this is. It is extremely important to open the patient's mouth as much as possible because that gives you enough room to look at everything you need to look at. If you don't open the patient's mouth fully, you're really going to be doing a disservice to yourself because you won't be able to see anything as you normally would, as you would like to. This is just another picture of the anatomy, just to kind of give a refresher before we see the videos that we're going to see now. The epiglottis is here at the top, and this is the vallecula is the space behind it where you would insert your Mac blade, and then again your Miller blade you would use to actually lift and cover the epiglottis. And then this is what you want to see. You want to see the vocal cords as well as these cartilages to show you that you're in the right place. And then this is another view of that as well, where you can see that this is the trachea and these are the vocal cords, and this is the place that you want to be. So now we're going to take a second to watch a video. This is a video of a provider demonstrating on a model how to intubate a patient. And they're also going to show you some of the important steps that you need, just like us checking the light before you start the procedure. So I'm going to start that for you all.
The next thing we're going to talk about is direct intubation. This is your blade handle, and you'll see there's a bar there. And this is your blade, and there's a hook. You see the hook goes over and clicks onto the bar, and you open it. And as you open it, the light will come on, and it will be secure in place. If the light does not come on, then you need to find yourself some new equipment that will work. There are two blades we can use. We have a curved blade, which is a Mac, and this is the one we most commonly use for adults. Looking at our Airway model, you're going to hold your blade in your left hand, and you're going to place the curved blade in this space, posterior to the base of the tongue, and you're going to raise up to see your airway. Alternately, we have a straight blade, which is also called a Miller blade. The Miller blade attaches in the same way as the curved blade, and you open it to have the light come on as well. The Miller blade is most commonly used in children because of their floppy epiglottis, and it's easier to see their airway with a straight blade. What you need to know about the straight blade is that it goes in a different space from the curved blade. To remind you, the curved blade was placed at the base of the tongue, and the straight blade is placed beneath the epiglottis to open the airway. You want to make sure that you have your endotracheal tube, and you want to make sure that you have a flexible stylet. The stylet goes inside the tube. It helps you direct the tube through the airway, and you want to make sure that it does not come out the other end of the tube and damage the structures of the airway. We recommend you put a bend in the top of the stylet so that it does not inadvertently get pushed forward. You will take your 10 cc syringe and you will check your cuff before you intubate your patient. You of course want to make sure that your balloon is deflated before you intubate your patient. The trick on the mannequin is that you are trying to line up the patient's airway so that you can see the cords clearly. I suggest you place the patient in a sniffing position, and you will take your blade in your left hand. You will sweep the patient's tongue out of the way, and you will think about lifting the blade into the opposite corner of the room. You do not want to just crank back, or you will hurt the patient's teeth. So again, you're trying to line the airway up, you take the blade and you raise it to the opposite corner of the room, and then you will need to look down to see the structures you're looking for. When you see the cords, you will take your tube, you will direct it to the cords, and then, making sure to hold on to your tube, you'll remove the stylet, you will inflate your cuff, you will place the CO2 detector on the tube, and then the bag on the CO2 detector, and you will bag your patient. Again, you'll be watching for color change in the CO2 detector, and you'll be listening to the patient's lungs on both sides and the epigastrium to ensure correct tube placement.
All right, so I'm just saying I wasn't able to read the comments during the talk. Sorry about that. But I did get some feedback that unfortunately this is the loudest that I could play the video. But we will give you the link so that you can see the video as well later on. You can have access to the slides as well. So sorry about the sound quality. But I thought that was a very good video, kind of demonstrating the importance of kind of checking your equipment beforehand and having everything ready. We actually have another video here that we'll be able to show you. that I'm going to be linking here in 1 second. It's a video that is available from the BMJ course. I don't know if you want to take over, Nico, while I kind of set up the video.
Yeah, I just want to mention that this is a very short course that is on opencriticalcare.org. So some of you guys may have seen it or directed your learners to it. It probably only takes like 20 minutes. There's a pretest, there's some written material, and then there's this video that will show. And Sandra's gonna play that in a second. It's a pretty nice video. There's one or two things that we would suggest they slightly inaccurate, but we'll point those out. And Dr. Salehi will definitely share the recording and PowerPoints after this. You can go ahead, Sandra.
Okay, great.
Ensure that the equipment is prepared and check that the laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting to intubate. Standing behind the patient with their head in the sniffing the morning air position, with the left hand insert the curved blade of the laryngoscope into the mouth over the right side of the tongue, displacing it to the left and upwards. Advance the laryngoscope slightly until the tip of the epiglottis can be seen posterior to the back of the tongue. Advance the tip of the laryngoscope blade into the vallecula between the epiglottis and the tongue. With the handle of the laryngoscope pointing away from you at 45 degrees, lift upwards and away to lift up the tongue and epiglottis to display the vocal cords and the laryngeal opening. With the right hand, insert the endotracheal tube from the right-hand side of the mouth, directly between the cords and into the trachea until the cuff passes through the cords. The markings on the tube at the incisors will show between 21 and 24 centimeters in the average size adult when the tube is in position. Remove the laryngoscope and inflate the cuff with approximately 15 mils of air to prevent air leaking during ventilation. Attach the tube to the bag and valve apparatus and ventilate the patient with the oxygen flow on 12 to 15 litres per minute. Confirm the position of the tube by auscultating over the apices of the lungs, the axillae, and the stomach. If it is not in the correct position, deflate the cuff and remove the tube. Resort back to bag and mask ventilation and repeat the intubation process from the beginning. If the tube is in too far, the right lung will be ventilated only via the right main bronchus. If this occurs, deflate the cuff and withdraw the tube 2 to 3 centimeters. Re-inflate the cuff and recheck the position. When the tube is in the correct position, tie it in place with cotton tape and attach the tube to the ventilating apparatus and ventilate the patient.
Thank you. And I would just say to everyone that, watching that video, two things I would point out. First, there's no stylet in the endotracheal tube, and that's an error. When you insert the endotracheal tube in, you're going to want a stylet in there. And then you should only be inflating your balloon really to 10 cc's at the most, not 15. Otherwise, I think that's a fantastic video, and we'll be sharing all these links. Go ahead, Sandra.
All right, great. Can you hear me now still?
Yes.
Okay, wonderful. So this is just a view kind of showing what exactly the tube looks like inside once you intubate the patient. And it kind of shows more of the anatomy, which is just very important to kind of review once you're getting more familiar with this procedure, as it'll be helpful for many different reasons. Just kind of help you navigate once you feel like you may be lost, because sometimes when you look inside a patient's mouth, things aren't as clear as you would want them to be. And then one important video that I wanted to show you is this one, is how easy it is to kind of mistake the trachea for the esophagus, because they can look very similar. So I'm just going to play this quick clip showing this is a person, this is an actual person. And you can see that what they're showcasing there, that's the trachea. You can see the cartilage on the bottom, and you can see the vocal cords slightly there. And they're going to be doing some lifting. And then now you see the esophagus come into view. So it is very easy to think that you are looking at the trachea, but that hole that you see there on the bottom is the esophagus, and then the trachea is actually more anterior to that, as you would expect. So it's important that when you put the tube, that you put it through these cartilages and that you see those structures and identify them clearly, because it's very easy to mistake one for the other, particularly if it's not something you're familiar with or have done before. And it does happen where you unfortunately intubate the esophagus. It happens rarely, but it's just important to kind of keep that in mind once you're taking a look in there. Okay, let me advance this. Okay, so now that you have intubated the patient, there are several steps, some of which were mentioned in that video, which is important for you to do. And in this slide, you can kind of see some of these steps summarized. You're going to want to confirm that you placed the tube. And there's another slide coming up about how to do that. You want to confirm that you are in the right place. And you can do that either with auscultation or end-tidal CO2. Once you feel that you are in the correct place, you're going to be securing the tube either most likely with tape or any other kind of device that your institution has to secure the tube in place. You will also then place an OG tube to decompress the stomach, because once you start to bag a patient or put them on the ventilator, their stomach will get filled with air. So you have to place an OG tube to help kind of decompress that overall. You're going to select your ventilator settings whichever are appropriate for the patient's size and condition. Medical condition, and then you're going to provide sedation and analgesia. It's very important that if the patient was awake and alert and oriented, that you do give them the proper sedation, because if not, they are not going to enjoy the sensation of being intubated, and they may dislodge the tube if they're uncomfortable. So it's important to remember that step. And then you will obtain a chest X-ray to confirm that it is in the right place and not in one of the main stents, or on the right side versus the left side. So there are several ways to confirm placement. One of the things that was mentioned in the video is to auscultate. This is very important to do. Once you intubate the patient, you listen for breath sounds and you make sure that they sound equal both on the right and the left. As mentioned in the video, if you're only hearing breath sounds on the right, or they're a lot stronger on the right, you're actually going to want to pull back the tube, because that means that you've gone too far. Given the anatomy is such that the right side of the lung points downward. So typically what will happen is that if you ever if you ever put the ET tube too deep, it's most likely that you're on the right side. So you would pull back, and you're going to want to make sure that you don't hear any breath sounds in the stomach as well. Over the epigastrium is where you'll listen. Another thing that you can do is look at the actual ET tube, as you see here on the bottom. Some people will look for condensation. That is not the most reliable method, but it helps if you're giving the patient a breath and you're seeing it condense when you're giving that breath. That likely means that you're in the right place. Other ways to detect that you are positioned correctly is either through CO2 capnometry or capnography. Here on the top right is capnometry. Essentially is pH paper that is detecting if you are getting CO2 or not back. Once you put this device, you put it on in between the ET tube and the bag mouth mask. It goes in between both of those, and it starts off a purple color. If you are in the right place and getting CO2, it will turn a gold color. Sometimes there's false positives that can happen, but this is a good way to kind of confirm that you're in the right place. But overall, the gold standard is end-tidal capnography, which you see here on the bottom right. If you are fortunate enough to have this in your institution, it's a great measure to see that you are in the right place. You will be able to see this waveform that you see here on the bottom right that indicates that the patient has CO2 and they're blowing it out. It's being blown out when you're ventilating the patient. Finally, you can obtain a chest X-ray, and you want the ET tube to be in the trachea, and you want it to be anywhere between 3 to 5 centimeters above the carina. As long as you have this, for the most part, above the carina and below the clavicles, you're usually in a good place. But this will help you determine if you're too deep or too shallow and meaning to make adjustments. Some of the complications that you have to consider are some of the things that we just mentioned now, such as a right main stem intubation. And if that's the case, you would pull back until you hear equal breath sounds. If you're in the esophagus, you would remove that and attempt again and ventilate the patient until you're in the right position. Sometimes you can successfully intubate the patient, and for whatever reason, the tube gets dislodged and you will have to re-intubate the patient. This happens. It's also happened that the patient dislodges it themselves. They're not properly sedated. or other things that could happen, and movement of the patient, not securing the tube correctly. And at times, the balloon that we inflated, that was discussed how it was inflated, sometimes there could be damage to that balloon, and you will get an air leak, and you won't be able to properly ventilate the patient. So in that case, you may have to exchange the tube or think of other things. And these are just some of the main complications to consider overall. So it's important to always have a backup plan. It's something that we stress, even for experienced providers. Sometimes you are not able to get the airway on the first attempt. Sometimes the patient has complicated anatomy. Sometimes the positioning is not optimal. The patient's not paralyzed fully. The ET tube is too large. There's different things that can happen, and you have to be able to troubleshoot and know that you have a backup plan. So typically, whenever we have someone intubate a patient in our emergency department, we usually say, you know, I'm going to intubate the patient with a MAC of this size and this tube. And then my backup plan will be a Miller with this size, or my backup plan will be to use video if you have access to video laryngoscopy, or it would be something like an LMA, which we're going to discuss now. So it's important to always have a backup plan. And it's important to also note that your backup plan, not only that, but every attempt that you do should be different. You shouldn't be trying the same thing over and over and over again. If you keep intubating the patient with a MAC 3 and the same tube size, you're probably going to get the same outcome, which is not be successful. So you have to always try something else. Either change the positioning, ask for an assistant to help put pressure on the outside of the cricoid or outside of the anatomy to help you kind of position. That's something that I don't think we've covered thus far, but you can actually have assistants kind of press down and help you kind of mold the patient, hold the patient in such a way that you will be able to get a better view. You can get a different blade size or type, different tube size, and then talk about the other things that we are going to be discussing next. And it's all okay to get a different person to try, or a more experienced provider. That is something that we have to do, especially like early on in my training. And I think even once Nico had to take over for one of my intubations, because for some reason I just couldn't get it. And then Nico was able to do it. So sometimes it's just, you have to be able to step aside and just try something different, even if it means a different person. So in terms of other things that you can consider using to help you if you're having a difficult time is the bougie. This is a flexible, it's kind of like a stylet, but not necessarily, it's a little bit more flexible. And it has a curved tip at the end that allows you to kind of not necessarily palpate, but feel the tracheal rings, so that if you are inserting this into the airway, you are able to feel those rings with this curved tip. And if you ever have a difficult airway, or you're having trouble actually putting the tube, you can use this device by loading the tube onto it, as you see on this picture on the right. Do we have time for this video, Nico?
I think let's skip the videos, remaining videos, but we'll send the links out to everybody.
Send the links, yeah.
Just so we can leave time in case someone has a question.
Correct. I like that. Yeah, this is a video just showing how to use a bougie, but we will give you access to that. Let me see if it's progressing. Okay. Other things that you have to consider in your back plan is that we have these devices called supraglottic airway devices. So if you are not able to intubate a patient, this could be your backup plan. If you are unable to successfully put it in the trachea, you can use this. And these devices are actually very easy to place. You just use a little bit of lubricant over the tip of the airway, and you literally just insert it into their mouth and kind of just push it through by lifting their tongue out of the way and just pushing it posteriorly in these pictures. And that is a very, very good way to oxygenate and ventilate a patient if you don't have the ability to intubate them right away for whatever reason. We also have a video on that you can see later on as well. It's about a minute in length that shows you steps. And finally, if you are unable to intubate a patient or ventilate a patient or bag a patient, any of those things, and all these other techniques have failed and you've done everything that you can, then you would have to perform a surgical cricothyroidotomy. This is a rare occurrence. I have not done one in my career yet, but it's something that you should know, or I know is a possibility of what could happen. And these are the steps. There's several videos online, but basically what you have to do is you have to create an airway from the outside using a scalpel. So as part of the airway kit in our boxes, we always have a scalpel, but something to keep in mind as a possibility of that what you may have to do. Essentially, I think that's it, Nico. So I don't know if we have time for questions.
Thank you so much, Sandra. That was really thorough, and the focus on every little detail was great, because this is a deceptively difficult procedure, and although the steps seem simple and it can be performed pretty quickly, it is dangerous. And some of the key points I took home from your presentation, Sandra, are pre-oxygenate at the beginning, provide lots of extra oxygen so you have a few minutes potentially with the patient off the oxygen to attempt to get this tube in the right spot. Have your supplies ready. You mentioned creating an airway box, a little box that's kept somewhere on the unit or near the patient's bedside that is pre-stocked with the materials that you're going to need. And you mentioned the checklist a few times and provided an example of one, which was great. And then during intubation, the most common pitfalls being placing the tube in the esophagus and thinking that it's in the lungs, and that can kill your patient pretty quickly. You mentioned placing the tube a bit too deep, and so it goes to the right side of the lung, and that causes the left side to collapse. And then you mentioned thinking of your backup plans ahead of time. So if you go and you take a look, or you try to pass the tube and it doesn't end up in the right spot, know ahead of time what your second plan is. So all that sounds like really, really great advice. And I hope it was useful for this group. I know some of you guys are trying to roll out some increased training for your providers on intubation. So I'll stop there and just see if there's any questions from the group.
Hi, Nico. This is Salihi. I have a question.
Go ahead, sir.
I want to know if the patient is intubated for example, in a long period, such as, for example, more than 5 days or even to 5 days. Is it necessary to deflate the cuff of ETT tube for a while and then inflate it again? Just I want to clear this. Thank you.
So the cuffs can break and lose integrity, and you can get a cuff leak. And so sometimes, if that occurs, you may have to replace the tube itself, because you can't replace the cuff individually without replacing the tube. And it's very difficult to successfully do positive pressure ventilation on a machine if you don't have a cuff that's up. Now, in the long term, these cuffs can start to erode the trachea, especially if they're inflated very tight. And like you said, if the patient is intubated for a very long period of time. I think, on the order of 5 days or a week, this isn't a huge concern. But in patients who might end up in the ICU on the ventilator for many weeks, and I see Michelle on the call. I think she's probably the only intensivist on the call right now. But for patients who are on a ventilator for many, many weeks, that could be a concern, some injury to the trachea from having constant pressure from a cuff. Something we haven't discussed in these calls, and we could always do that at some point if there's a desire, is that one of the things you can do in a patient that's been on the vent for a long time is you consider doing a tracheostomy. And what this does is it shortens the length of the tube, because the tube goes into their neck rather than all the way through their mouth. And oftentimes it makes them a little bit easier for them to breathe. It requires less force, and it makes it easier to liberate people from the ventilator if they have a tracheostomy. That's a different topic that we can always talk about more in this session, and we can bring somebody who can go over that procedure if that's something that's desired from the group.
Thank you, Nico. Got it.
Any other questions? We'll have Sandra share the slides with Alex, who can get them out to the group. And the slides will have links to many of the videos. So you guys can feel free to watch them. These are videos that Dr. Lopez has kind of gone over and ensured that, you know, they're accurate and appropriate. And we're here to support you, not just during the session once a month. So if you're creating training materials or have questions, feel free to email or contact us, and we'll get you your support. All right, thank you very much, everybody.